going to be a track on which he's going to sprint, taking the message for the desired and prayed for prayers. Ladies and gentlemen, my colleagues from the 3 member states, I don't know what you do in your courtship and romantic stage. Here in this country, when a woman is about to say yes, and then the gentleman approaches, is going to deliberately hold his paces and walk so slow so that the guy catches up with him. She is not going to deliberately say, I'm waiting for you, come and speak to me. But he's going to walk so slow that the guy catches up with him and indicate that things are going to be all right. We are expecting our honorable minister, and like that girl, we're going to hold our pace and not rush, lest the minister doesn't catch up with us. So at this point in time, we shall go for a break, have tea, and by which time, probably when we are done, the minister shall be in our midst. Like that girlfriend, almost would be waiting for the suitor to catch up with her. We want the minister to catch up with us. Remember, I have a new title now. I am a host. Good morning once again. Let us enjoy our break. Thank you. Sorry, ladies and gentlemen, we're not going very far. Our tea is just served outside. We shall mingle, we shall have tea, but we shall be waiting. Thank you.
1 2 testing 1 2 1 2 senda nabutswi is it right 1 2 testing 1 2 1 2 1 2 testing 1 2 1 2 1 2 1 2 1 2 1 2 1 2 testing 1 2 1 2 1 2 testing 1 2 1 2 kwenda njani ku standard sharp 1 2 1 2 yiple nang nai la afaka pita o2 o2 la etengwa afaka o2
manje lo khuluma ngani
nyalo number 2 number 2 1 2 1 2 1 2 1 2 1 2 1 2 1 2 1 2 1 2 ngiselo flange o testa sona asengisonzele ngala yabanza noma kashisa ithothe okay 1 2 1 2 1 2 1 2 1 2 1 2 1 2one two 1 2 1 2 1 2
break. I am pleased to welcome our Honorable Minister for Finance, Babi Reichenberg. We have here, Honorable Minister, our delegates from the 3 member states, the Republic of South Africa, Botswana, Namibia. We have here, Minister, esteemed personnel from the medical and legal fraternity. The MVA fund here is represented by the chairman, the executive staff, and the media. Honorable Minister here to capture it all. We are pleased indeed to have you in our midst, and this lends a very big blueprint on the significance of this conference, the Regional Case Management Conference. It is here this time around in Eswatini, and we are hosts. When I entered this room, Minister, I was a program director, and I've since been elevated to be the host. So that's a landmark and my takeaway from this conference. Thank you once again. We have again Dr. Mhlanga representing your colleague and counterpart, the Honorable Minister of Health, Babe Matsebula. I don't know what is going in his mind now, Babe Mhlanga, acting for a minister. If maybe he has butterflies in the stomach, or he has birds flying in his mind that, what if then I am the minister? It is all in our prayers. 2028 is just around the corner. Thank you, Minister. I'll take this opportunity, Honorable Minister, to request your acting Principal Secretary to come and introduce you to the congregation here. A little ground has been covered, Minister. We didn't want to take gigantic steps forward because we're looking forward to your coming. And now we are honored you are here. We just didn't want to take it too far until you are here. When you are in the yard and it's your wedding day, you are not going to be pleased until your parent is here. Indeed, Minister, we thank you for your wisdom and guidance of the fund. Through all the things that the fund has been mandated to do, you've been steadily holding the hand, and indeed, it is transparent for everyone to see that despite all challenges that may be there, the fund is serving its mandate. Thank you, Minister. Stawucela wena PS uthandazelwe PS ungaketi la sithandazile nje siyathandaza nanyalo. Please come forward and introduce the minister.
Honorable Minister, Honorable Chairperson, I forgot Acting Minister of Health. I'd like to also recognize you, distinguished delegates, delegates from sister funds, healthcare professional, SMVAF fund leadership and staff. Ladies and gentlemen, I greet you all. Standing before you is Nompumelelo Msibi, the Acting Principal Secretary in the Ministry of Finance. However, I receive what has been declared in the atmosphere, Chairperson. I've been given a brief assignment of introducing my minister, the Honorable Neil Rickenbeck. And without any further ado, Minister, may I take this time to request you to come and make your address. Thank you. Thank you, Minister.
Please be seated, everybody. No, one doesn't stand up for a minister normally. Not necessary for me, that's for sure. Right, and thanks for waiting for me slightly. My apologies for coming a bit late. There's just a lot of other balls in the air, unfortunately. So first of all, yeah, acting Minister of Health. In that case, now that you've been recognized and been put on the spot, I'll keep it there. Honourable Chairperson, distinguished delegates, delegates from sister funds. And it's lovely to hear that the sister funds are here today. It sounds like SACU, just we missing Lesotho in that case. Otherwise, we would have had the SACU team with us here around in Eswatini. Healthcare professionals, the ones that really make sure that things get done on the ground. SMVAF fund leadership and staff, all those here present. Ladies and gentlemen, good morning to you all. Thanks for having me. It's an honor and a privilege to address this distinguished gathering at the Sinepetelo Motor Vehicle Accident Fund Case Management Conference. The theme, Integrating Care, Bridging Gaps in Healthcare for a Better Outcome, is not more timely, but strongly aligned with our national development agenda and Eswatini's commitment to the Sustainable Development Goals, what we always refer to as SDGs. As a nation, we have pledged to achieve the SDGs by 2030. As much as it is seeming very ambitious at this stage, we are still saying to ourselves, we're heading towards it. We are going to continue to do our best to close the gap. But among them, we have goal number 3, which is good health and well-being. And it stands at the heart of today's conversation. It calls for universal health coverage, access to quality essential healthcare services, and financial risk protection for all. Integrated care is the bridge that connects this vision to reality. It ensures that no patient is treated in isolation, that physical healing is supported by mental and social rehabilitation, and that our systems work together, but not in silos, to deliver better outcomes. The Sinepetelo MVA Fund has long been a pillar of social protection in Eswatini. Its evolution from a compensation-focused institution to a proactive, patient-centered organization is commendable. The Sinepetelo Motor Vehicle Accident Fund, what referred to SMVAF, continues to fulfill its central role, which is compensating road accident victims and restoring livelihoods. Over 775 million emalangeni has been dispersed in claims over the last 4 years, directly supporting individuals and families in the most vulnerable moments. Compensation thresholds are currently include up to 1 million emalangeni per accident for personal injury, 10,000 emalangeni for funeral expenses, 350,000 each for loss of earnings and loss of support, 150,000 for general damages, which is generally for pain and suffering. These limits are currently under review, and we anticipate an increase of up to 3 million emalangeni per accident, signaling deeper care for victims. At the moment, the legislation is in the House of Assembly, and we should have it through there by the end of the week, and it will go to Senate. We're hoping before, in fact, we need to make sure that before we go into our year-end shut as Parliament, that we do get it through both houses. And so, yeah, we all work together to make sure that it is done. Thank you. No, I'm more reaching out for all the support that I need to make sure that we do get it through, but thank you. Through its case management model, 2,866 claimants have been treated and rehabilitated within the last 4 years. The fund aims to coordinate care across providers and disciplines, to support long-term rehabilitation and mental health services, to digitize claims and patient records for transparency and efficiency, and to partner with public and private stakeholders to extend its reach. These efforts not only improve lives, they're advancing our national and global development goals. The Ministry of Finance is committed to enabling this transformation. Our fiscal policies are increasingly aligned with the SDGs and the principles of integrated care. This includes outcome-based budgeting, which is prioritizing results over procedures. Right now, our new IFMIS program we're busy installing, which should be live in this next financial year, is very much outcomes-based rather than the way it's currently being done. Investments in rehabilitation and community health infrastructure, or support for digital health systems and data sharing, and public-private partnerships that drive innovation and efficiency. We understand that every Langeni spent on integrated care is an investment in human capital, economic productivity, and national resilience. Ladies and gentlemen, bridging the gap in healthcare is not the work of one institution. It's a collective mission. It requires that government, civil society, healthcare professionals, and development partners work hand in hand. It demands that we listen to the voices of the patients and the families, and that we empower our frontline workers with the tools that they need. SMVAF signed MOUs with key partners, including public and private healthcare providers, specialists, and the Ministry of Health, to ensure integrated care for survivors of motor vehicle accidents. To our healthcare professionals and case management, your work ensures that care is not fragmented but unified, and your compassion turns our policies into real healing. To the MVA Fund, or SMVAF Fund, thank you for your leadership and your innovation. To our partners in development, thank you for your unwavering support. To all stakeholders here today, thank you for your commitment to building a better Eswatini. We would like to acknowledge the International Case Management Week, which was on the 12th to the 18th of October, 2025, under the theme, Guiding Journeys. Let this conference be a catalyst, not just for conversations, but for action. Let us inspire new models, forge new partnerships, and reaffirm our shared commitment to healing. Together, let us bridge the gaps, strengthen our systems, and build a healthcare future where every recovery is a shared triumph. Thank you so much.
Thank you, Ndvuna Yengosi, lehloniphekile, Honorable Minister, for this all-capturing speech. We are delighted to learn that we have a political will that is encouraging us in these footsteps to integrate and to innovate and empower our endeavors in creating a better outcome for people, especially as per the dictates of our mandate, who are injured on our roads. Sibonga kakhulu, Minister. I can tell from the silence that they've been waiting for you and they are indulging and taking it all in. Maybe by the time we leave the room, some people would want to be doctors. It's okay, they can serve in this space. Already your CE Minister is indulging. He's got better and good words for the medical terms, not the ordinary. So here's the terminology. Before you know, you might have a doctor for a CE. Thank you. Staucela Chairman, Mr. Kina, bantu abakho-chair, bathi kukhona labafuna kukuphathisa kona, so that you can have a firm handshake with the Honorable Minister. After Chairperson, you have shaken the hand of the Minister. We will request for the honors, your Minister, for a photo shoot. People say pictures don't lie. The picture you'll take today will go into the future to say, I once rubbed shoulders with the Minister. I was there. So it is important. I'll ask Chairperson, your presidency, to take a picture with the Minister, also with members of ESCO's MVA Fund. Ndawucela na Dr. Ngobe, ngicele His Lordship, Mr. Masugu, and then I'll ask my sister Lydia from Botswana, and Eva from Namibia, and Mazil from the RAV. Ndawucela na Dr. Mhlanga, in his capacity as a representative for the Minister, bese ngicela na Dr. Fortunate Shabalala, who, Honorable Minister, is chairperson for a Piliani Clinic, our baby at Singapetelo MVA Fund. Then the protocol will follow after that. Chairperson, thank you very much.
Sometimes I forget he's a former teacher. He speaks for too long. Honorable Minister, on behalf of the fund, may we give you this token of appreciation. You just came from
a long trip to the US, and I know how engaging those conversations there were, but you still came and honored this invitation from the deepest parts of our hearts. This is our appreciation to you, Minister. Buya Dlamini Ntosi Mpopo. Uyaqala yini?
Thank you. Thank you, Chair, for the gesture. I'll ask, I'll request that the photo shoot takes place here for the personalities I've requested. You know, we prepare for pictures. So this is a last minute preparation. Yeah. So innovation is taking place right away. They are switching off the lights. Very innovative. Come, help. Just lift the bricks up, okay. Okay.
Honorable Minister, let me start by acknowledging our host and our Honorable Minister, the Acting Principal Secretary, the Chairperson for SMVAF MVA Fund, Board, Your Lordship, Babe Masuku, distinguished medical practitioners, legal practitioners, distinguished delegates, especially from our three sister countries. And ladies and gentlemen, good morning. Now that the shoes I'm wearing now, they fit me very well. That I've done with the protocol, Honorable Minister. This is what I enjoy the most. I'll be going through this presentation on status update on road safety, but briefly, and then zero down to the road crashes as statistics, and somehow explore through the severity of injuries. And thank you for your attention and listening. We're trying to think through together how to bridge the gap. In terms of my short presentation, as it is reflected on the board, I once also taught in some few years, host. So I'd ask you, do you see the slide? Thank you. This is one of the very important slides in the 14 slides that I'm going to go through. In terms of updates, the country has ratified the Road Safety Charter, and quite recently, which is in November 2020. And we also have moved as a country to develop our road safety strategy, which is 2023 and 2030. And you just look at the duration of our strategy, it's up to 2030. Then it would then remind you that we have a global commitment that we need to adhere to by the year 2030. Then average fatalities per year, this is what is really worrying, 200. And we're speaking of lives here, delegates, correct? 200. That is per year. So in our conference, we need to look at how we dialogue around this. And then serious injuries, which might also turn into fatalities, 700 per year in a 1 million plus population. So, but on that note, let's move and appreciate the developments that the country has moved towards enacting the Roads Authority Act of 2023, which also enabled us to move towards a road authority board of directors that has been established. When we look at other initiatives, global initiatives, because when we look at road crashes, we also have to look at other circumstances around road crashes. One of them would be some incidents which occur in the roads, and also would have some other implications, like in terms of when the incident occurs, it also involves other pressures like hazards, which are also in development. So Eswatini, as a member state, has shown some appetite to look at our neighboring countries and look at cross-border initiative for the future, so that when we respond locally in our road crashes, we also look at Emaswati being victims in our adjacent countries. Either they are going to visit or they are coming back. Then we then had to look at, under road safety, incident management system, which is a regional initiative, and then Eswatini has joined that initiative, which is the Road Incident Management System Initiative, which involves about 6 or 7 member states in the Southern African region. Then that speaks to looking at your neighbor and the borders that you are sharing. So for this slide, we are just highlighting that we are sharing borders with South Africa, and quite a number of them, about 11 or so borders that we are sharing, that we need to look at those situations. Beyond our country, we also have to extend to our adjacent neighbors. And it's not South Africa alone, even Mozambique, we also share borders. So when we speak of case management going forward, we have to look at how we embrace other developments which also affects our own people in Eswatini. It's either they're coming through Mhlumeni, or they're coming through Goba or Namacha from Mozambique, but they are Emaswati coming back home. So in that note, on that note, then because we have joined this regional initiative, which also looks at road crashes and then road incidents management system, then we had to work on a number of initiatives. One of them is the country is now a member of the road incident management system in the region. Then we appreciate that move. I think we deserve a big hand of applause for that. Because we are now a member of the road incident management system, we're now collecting all role players to look at how we then act into an incident when that particular incident occurs. Then the Road Incident Management Regional Initiative is working on a strategy that speaks to 5 pillars. I will not lecture you today for the purpose of this conference in terms of those pillars, but for you to appreciate that we are looking at Eswatini developing structures and programs for road incident management system, working in partnership with South Africa and Mozambique. Pillar number 2, resource allocation and management. How much resources do we have as role players in the incident? We need to declare all our assets. What do you have in your pocket, so that we know the capacity of the country in terms of managing an incident. For instance, if we look at the key role players, we need to know what REPS has, what EPR has, what NFRES has in terms of resources to manage an incident. Number 3, communication and technology. Then training and capacity building and public outreach and liaison. So these are the pillars that we would work under in terms of these future developments. For road safety issues, we're now embracing road incident management system, which is coordinated at regional level, and we are now working closely with member states to look at how SADC, the organ of SADC, can support this initiative for the member states. Of course, having given you an update in terms of road safety, those key highlights, we now need to look at our own statistics as a country. We have an initiative where we are looking at establishing or strengthening a national ambulance service. When we mean national ambulance service, we mean a centralized system that will link to bring all the parties into the table, and then we coordinate our emergency medical services together, be it private, be it mission, but we come together to look at how we can work together. Distinguished delegates, standards don't lie, and they need to be measured, and then we need to account in terms of our response. So in comparison with other countries like South Africa and UK, we look at how have we planned our standards, okay? One, in terms of the space where we are operating, because we are at the hospital which never gets full, which is outside the hospital. That is the pre-hospital setting. then that is the first entry point of our case management. Therefore, we need to measure what we do. One, how do we respond in urban setting, and how have we categorized our urban setting, and how have we categorized our rural setting? So as a country, and in terms of progress and updates, we have that 80 to 90% percentile attainment of 8 minutes response time for every call that is in the urban setting. For anything that happens as an incident, for road crashes in an urban setup, within 8 minutes we should have rescued that life. Are we still together? I'll say here a yes at the back. Are we still together? Thank you. And then in rural setting, 14 minutes, 80%, 80 to 90% percentile attainment. But when we compare with our counterparts, we see how they have, we were benchmarking in terms of how are we as a country. But in terms of coverage planning norm, our ambulance requirement per 10,000 population, it speaks to 1 ambulance. Please don't ask me how many ambulances do we have now, but just look at the standard that we are planning as a country. So with that, I also want to also bring that teaser to say in our case management, we're dealing with lives. We are saying 200 fatalities per year. They say statistics don't lie. This slide says the chance of dying in a road crash depends on where you live. This is what is challenging me day and night. To say when we look at the Americas, that is mortality, right? And then Europe, the Eastern Mediterranean, and then we come to Africa. We have 26.6%, higher than any of the regions. Do we agree that it depends? This tide, Honorable Minister, must change. To say the chance of dying depends on where you live. It speaks to systems. It speaks to behavior. It speaks to a number of issues that we need to interrogate and think through. Is our behavior correct? Is our driving, it's like when it gets to a season, a particular season, we're in the mood of doing something. Then how do we collect our statistics? We have what we call a centralized road crash desk, where we are calling all our partners, social partners, that we now need to unify a unified number that we all log in, so that all our cases can be triaged and followed up, so that when it gets to modalities of compensation, we have all gone through a similar system. So we're saying currently with the road crash desk that has been established under SMVAF MVA in partnership with Ministry of Health, we're seeing information sources as our surveillance system coming from a number of various sources, including the community itself, where they're able to log in that information. Then we send signal, and the raw information is triaged quickly and verified and monitored, such that whatever information that triggers down and filters down triggers a response, and that information that is not warranting any response is then discarded. So this system is what we are building up, so that when we reach our 2030 goal, we have a unified road crash notification and centralized dispatch system. We have a unified road incident management system. We know who is the incident manager at what a particular time. Then because of that system that has been built, let's look at the figures. This is according to our road crash report statistics from the road crash center, which is 977. This is according to the second quarter report, 1st April to 30th September 2025. Let's see where we are right now. Is there any improvement or decline in comparison with the previous year in the same reporting period, 2024 and 2025. When we look at Woho down there, by 2025, in the reporting period, 307 cases. Lubombo, 131. Manzini, 268. Shiselweni, 70. In total, 776 cases notified and responded to, as opposed to 667 cases in 2024. So this is indicative, showing us that even before we finish this year, we are in the rise. Okay? Remember, 200 fatalities per year, 700 serious injuries within a year. Then that speaks to something. Okay, let's move on. If we look at monthly trends, this is showing that, and we compare with the previous year. You can actually see May, June, July, August, and then September, they were more like same. But from April to September, we were on a steady increase in terms of the monthly trends. Our biggest worry now that will shift our discussion is the pedestrians. Can we all say pedestrians? Because we sometimes become a pedestrian tomorrow and today, right? I don't know what's happening with this, but this is now showing a different picture altogether, and the trends are just increasing year by year. For Hoho region, 73, Lubombo 26, 58, Shiselweni 7, in total 164 cases were pedestrians in this short reporting period. So the conference must think through with us in terms of what has changed. Is it behavior? Is it we have forgotten? But some of us who were in the schools yesteryears, we were taught when you cross the road, you look on the left, you look on the right, you look on the left, you hear a sound, no sound, you cross. And we never forgot that. Is it still occurring nowadays? And we used not to have anything horsed in our ears when we cross the roads, with due respect. I'm not saying wearing something in your ears is wrong, but we did not do that practice in our yesteryears. Okay, so pedestrian crossings are a challenge to us. And then again, when we look at the burden, Hoho is taking the bigger chunk in terms of the number of pedestrian cases in our region. So again, that also speaks to we need to do something. When now we categorize our incidents, because each incident is categorized in our road crash center. Is it a low level or medium level or high alert level in terms of level 1, 2, and 3? So out of all the cases that are reported, there were 9 incidents that were categorized level 3. Level 3 triggers, and of course each case is attended to. But level 3 is of high magnitude, such that we need to mount, we need to activate our incident management system for us to respond to level 3. So 9 incidents. It could have so many people, but this is also showing that it's on the increase. Then when we categorize by severity of cases, when we triage in terms also of priority 1, which is serious or critical, very critical injuries that requires us that we evacuate straight and alert the receiving facility that this incident or this case is at this magnitude. There were 42, and then priority 2, there were 105. While priority 3, when you look at these figures, there are more than the cases that are reported, 1,215. And of course, those that we have lost, there were 34 in the reporting period. Those, the P4s, sorry, we were supposed to use the black color for P4. but for reasons, we are choosing now to use another color, a reason space known to us to say the P4 is the one that has expired or died. So this gives us the total. So again, when you look at this severity of cases that have been triaged and classified, you can actually see that more work has to be done on the priority 1 and then priority 2. Of course, not forgetting the priority 3, because anyone can present with priority 3 and immediately suddenly change to priority 2 or priority 1 within some few hours. But some of these cases in priority 3 have, they're inflated. They're showing that we have 1,215. Why? Because some of the cases, when you attend in the scene of the incident, some of them, they refuse totally to be treated. Some of them run away. When the case has been locked in, that person runs away. Yet the case has already been locked in. Some of them, they say, I'm fine. You evaluate in the scene and then they say, I am very fine. Host, I am just concluding by saying we still are facing a challenge, because we're also counted amongst the globe to say, do we have specialist knowledge in creating safer roads and vehicles and road user behavior, and designing and operating a well-functioning post-crash system? Do we accredit our road safety, accreditation of road safety as a field of study? Those are the issues. And then short-term courses and continuing education. We appreciate our partnership with the SMVAF MVA, which has shown and yielded some positive steps towards managing cases and also including rehabilitation. We will speak to this later. We now have the Act, the Health Act of 2023, which looks at a number of issues that needs to be, where we need to develop some regulations so that we manage our cases efficiently, innovate, integrate, and empower. Chair, food for thought on my presentation, enhancing organizational resilience through systems thinking. Let's look at systems that have worked and build resilience to those systems. Deployment of end-to-end artificial intelligence in Road Crash Desk Center, so that we zoom in into the site and see what's happening directly. Of course, that goes with workforce capacity. And then let's evaluate evidence validation. What has worked? Let us showcase and then expand or scale up for what has worked. Thank you very much.
Thank you very much, Dogotela. Sivile ukuthi leqathulo leti ke leti betitakombamba. You were fitting in these shoes. That's to say, maybe the others, you find them too big. You'll fit in those as well, Doctor. When the time comes, you'll fit in those shoes. Dogotela, I concur with you that the pedestrian issue, it's becoming a panacea on the road. Our young souls, adults as well, are catastrophically affected. If probably we were to remember that maybe not all pedestrians can be lucky to be motorists, but I bet you all motorists are at a point in time pedestrians. We all pedestrians. The moment you park your car and cross to the other side, you are no longer a driver. You are a pedestrian. So in your driving, you are up to look out for pedestrians the same way they should look out for you, the other motorist, the moment you disembark from your vehicle. But that is not the spirit. There seems to be disharmony between the man on the ground and the man on the driver's seat, and there comes collisions, fatal collisions for that matter. I have a panel here, Honorable Minister, that is going to deliberate on the presentation Dr. Mhlanga has just given us, and it shall be facilitated by my sister from the land of diamonds, Lydia Nkoma Masilo, and our panelist will include our very own Dr. Shabalala, erstwhile chairperson of the Road Safety Council of Eswatini, and the incumbent chair of our own Ekupilen Clinic. Leon, my colleague from the Road Accident Fund, Leon Mayer, shall also form part of this panel. Then there's going to be Eva Amakali from the land of the brave, Namibia, and then we shall have Dr. Ngube. I invite these esteemed panelists to take their seat up here. You are not going to be grilled like the Mkwanas here. Here you are going to share with us what your take is on the presentation Dr. Masitela has just given us. Dr. Shabalala. Is Lydia here? Okay, thank you, my sister. Chairperson, you know Lydia know me as an avid soccer player. When we started the inter-fund games, I was called International Man of the Match because I outshone every other people there and scored goals. Masugu is witness. I was terrific. I was a terrific striker. So besides being a host, I'm an International Man of the Match. Nobody has taken the title from me. Thank you.
Thank you very much, host. Ladies and gentlemen, as I already alluded to, my name is Lydia from the land of diamonds. From Botswana SMVAF Fund. Please allow me to ride on the protocol that is already established. But with that, I'll honor the Honorable Minister of Finance. And ladies and gentlemen, it's really a privilege for us to be part of this today. And thank you very much for the kind introductions by all the speakers, how they recognize the sister funds. And we really love to be part of this. Today's theme, or this conference theme, I really love the theme because it's quite relevant to our environment. It's quite relevant to the limitations that we have as Africa or as Southern Africa. So really we need to bring all the resources that we have together. We need to integrate the care for maximum benefit. So thank you very much, Eswatini, for coming up with that theme. I would like to welcome you to this second stage, or this vital conversation on us integrating the care across border in trauma support or trauma management as SMVAF funds and the health fraternity. Today's panel or panelists are experts from case management MVA fund, experts from healthcare systems that we have, influencers of health policies, innovators in this sphere, who have come here to explore how we can build inclusive, cost-effective and interoperable systems within our environment. And we are looking into systems that will serve everyone. When you talk about road traffic accident, they don't choose. Whether you are rich or poor, whether you live in Mbabani or Hlolo. Rural areas or wherever you live, the RTAs will find you. That is our experience in Botswana, and the most painful part of it is that amenities are only in urban areas. So what's happening to that person in that village? And that's why we are talking about exploring, integrating the little that we have. And to discuss this, I have my panelists here. Thank you, the host, for introducing them, because I didn't have all the information on the panelists. We have Dr. Shabalala, who is, just a moment, the senior lecturer and HOD for Community Health Nursing Services at the University of Eswatini. And the gentleman on my right, who's Dr. Ngube. Nklang, thank you. Sorry about that. Eva, my sister Eva, that side. And Lynn, on the other side, Lynette, from REF. Please, can you join me as we welcome them? Ananda already seated. Thank you, panelists. To go into it, part of our discussion will touch on what has already been discussed, but we also have questions for them. I'll start with Dr. Chabalala from your community based healthcare or experience. The first question will go to you. How can we ensure that integrated care models are inclusive of marginalized and undeserved populations, especially in rural or low resource settings? I hope you got the question. Okay, ladies and gentlemen, that will be Dr. Chabalala from Community Health Nursing Science. And I do have another mic here for you. Thank you. Yes, I think you press somewhere. There we go. Yes, please, thank you.
Good morning, Honorable Minister, the acting minister next to me, the chairperson of the board, the PSs here, and all the dignitaries. I've been introduced as a lecturer, and I'm not used to talking sitting down. I feel like my message isn't gonna be able to reach out. So may I be allowed to stand up, please? Thank you so much. I think my question speaks to the issue of inclusivity. If I summarize it, it speaks to the issue of inclusivity. How do we make sure that everyone is included and provided with the care that they deserve as human beings? We'll be speaking to that. We are lucky in Swaziland that was a very small country of about 1.2 million people. They usually say if you are to put us in South Africa, we would probably be the smallest province because we're even smaller than Gauteng in terms of size. I'm not so sure. So it makes it very easy if we're to include everybody in care, particularly in the topic that we're talking about. However, the challenge that we have is that it will seem that Swaziland or Eswatini is between Babane and Manzini, for those who know. Any other place outside of that is just the other, the othering. So how can we actually bridge that gap where it is not just in Babane and Manzini corridor, where the business and economy is happening, but also the people who come from afar to come and make that economy, that business work? How do we make sure that we include them? Our political system is built upon what we call constituencies, or tinkhundla in the local language, where people can come together and congregate there and discuss issues of community, regional, and national importance. That is one structure that we can use, where we're saying ourselves here, MVA and the Minister of Health and everybody else involved, they must leave Mbabane and go to these areas where they can talk to people, discuss with people, and provide the services in those constituencies because they're closest to where the people are. That is one thing. The other thing, the Minister of Health has a policy that is underpinned and built upon what we call primary health care. And primary health care speaks to the issue of community empowerment, community involvement, community participation actively. If we use that strategy to say participation, involvement, and the community being part and parcel of every decision making, we need to use that approach to say, let's go to the people, talk with them, not talk to them. If we talk with them, I always say to my students, when a patient comes to the hospital and see me or see Dr. Ngube, they already know what is the problem. They probably already know what could work for them to address that issue. So if we talk with them, they are able to probably provide some solutions that can work for them in order to reduce the statistics that we're talking about here. So active involvement and participation of the communities where they are will actually help us deal with this. It will go further and also capacitate and empower them with the knowledge not only to respond, but also to prevent the occurrence of these accidents that because the major issue I want to believe that causes the high pedestrian rates that we're seeing in terms of crashes is lack of knowledge when to cross the road, how to cross the road, both on the side of the pedestrian and on the side of the motorist. Currently, motorists in the country, they still have this notion that the road is for cars. Yet the road is a shared space where both the person who's walking and the person who's on the car, either as a driver or as a passenger, they all have an equal share of that space. But if we have a mindset that says, no, the space is for cars, then we have to change that. How do we change that? By going to the people, educating them. And educating them brings us to the fact that you cannot say it once and expect people to change. Up to today, more than 2026 years ago, when we started to hear about the coming of Christ, there are still people who haven't repented, Your Lordship. So we need to repeat and repeat and repeat the message. The issue of response and exposure and response, that theory, is let people be exposed frequently to the same message until it's running in their head even when they are asleep, that then they can start to change their behavior. If we can look for an example, I don't know how many minutes I have, but if we look at the behavior in Eswatini, some 10, 15 years ago, we were not fastening our seat belts. But with the frequent exposure to the message on how and why we should fasten our seat belts, and of course, the punishment if you haven't done so, very few people today maybe are not fastening their seatbelts. So that is the exposure dose that we need in terms of how can we make sure that we share the space with pedestrians, with people who are using the space on the road. We need to do that. But we also have a very important structure in the country, the traditional leadership. You know, we are such a traditional society, particularly in the rural areas, where when the chief says, Banvabam, this is how we should do things, they are likely to listen, at least the older ones. I don't know about the younger ones, but I know that I would listen. So the chiefs and other traditional leadership in the country, they still have a voice and they are still listened to. Lastly, it is our members of parliament, the lawmakers. I always feel so bad when a lawmaker will say one thing when they're in the chambers and the behavior outside is totally different of what they are saying. You know, they must act as role models, they must speak out, they must act what they are speaking out for things to change. So we need to have a very deliberate effort to make sure that people are empowered, people are involved, people feel like they are appreciated for the effort that they are putting, but also making sure that we move out of the spaces of comfort and we go where the people are. And by doing so, and as well strengthen the health systems. I think that is another point, strengthen the health systems in the rural areas, because right now, you know, when we're talking about a road crash and whether a people will have a disability or will die, we're talking about the 1 hour, what we call the golden hour. But in the health practice, it is not just the 1 hour. We're talking about the golden 10 minutes. The first 10 minutes will determine whether that person will be a total cabbage or that person is gonna survive. And what we do within those first 10 minutes, those first 3 seconds, if it involves a serious head injury, will determine the life of that person moving forward. So we must have the systems that are in the Mbabane Manzini corridor be also applied in the health facilities that are out there in the facilities. Thank you so much.
Thank you very much. I liked her point where she said, talk to them, involve them. When you talk about community, when you talk about those vulnerable communities out there that we are not bringing services to, it's very important to get them involved. Thank you for that. I think most importantly, because our theme is talking about better outcomes. And when we talk about better outcomes, how do we measure better outcomes? And the first thing that comes to my mind is that patient-reported outcomes, those will be the better outcomes for them. I can see the minister wants to to say bye to everyone. Thank you very much for honoring the conference.
Thank everybody. Sorry.
Yeah. All right. Okay, we'll give them a moment. Thank you. We can continue. I think I was saying, when we talk about better outcomes, we should think about the patient or the claimant reported outcomes. Those are not our outcomes, those are how they define better. So involving them, as she said, will help us really come up with the metrics that we are going to use to say, now we are offering better outcomes. And she also talked about, you know, what is available in these communities. We need to see how we can leverage on that. And political support, very important. It's a pity the minister had to go somewhere, but I'm sure there are other officers here who are able to reach those offices. Political support in whatever we are doing is very important, because these are the people who influence the health systems. These are the people who influence law enforcement. And these are the things that really we need as funds. And we also, she referred to the golden hour. And with that, I'm going to go to Patrick. to talk more about that. On one of our questions is that how can MVA funds across SADC collaborate to ensure continuity of care for accident victims who cross borders? We still have the issue of early interventions. We still have issue of early responses. Let's talk about that. Okay, Patrick. Thank you very much. She has the other mic, yes.
Thank you. Thank you, host. The question speaks to cross-border collaboration and strengthening of emergency care within the golden hour. And how can we achieve what our maximum benefit in that initiative? So I would say we are very fortunate as member states that a new initiatives have come into play, which we can ride on. One of them is the collaboration of MVA in member states together with the Road Incident Management System initiative, which is a regional initiative that has been spearheaded. It is now going to soon be endorsed by SADC as a platform that we can ride on. That initiative has already been activated, and now, like us as Eswatini, we have already drafted a protocol ourselves and South Africa and Mozambique, a draft protocol to look at our defined road incident management system within the golden hour in these 3 neighboring countries. We also have started to pilot, because that is also going to bring evidence. We have, in one of our borders, we have an ambulance that is fully stationed 24 hours at Oshuk border. It's our border with South Africa, the main one. So that, and then we have mapped the adjacent areas. What other support systems in terms of road incident management system are available adjacent to that border? We've defined that so that we look at our response time. This is bringing me to say, defining standards with clearly defined response time in the package of cross-border initiative will really see us yielding the fruits of better health outcomes. Because if an incident happens in Carolina, which involves Swat, if we are able to rush quickly and save lives, or we meet halfway with South Africa and save those lives, that can yield us to better health outcomes. But systems which goes with the personnel and the infrastructure are very key in a successful response. Capacity goes with the strength of those countries that are collaborating. If we share what we have as member states in our joint collaboration, not saying give each other, but share what you have so that we know who has capacity to do what in that response. So in a nutshell, I would say strengthening of emergency medical services within the golden hour seeks for our partners, member states, to look at protocol development, look at defining standards of response, look at capacity building of response, and look at a simulation exercise so that we test what we have planned, it works or not. Thank you.
Thank you very much, Patrick. Thank you. A round of applause for Patrick. Thank you for bringing this up, the protocol. I really pray and hope we implement this. In Botswana, we have that weakness of having beautiful protocols, and sometimes the implementation is not there. So really, this is the committees that he's talking about for road safety. This is a strong weapon that we can use. This, when you talk about cross-country, all of us here, I know Botswana, like going to South Africa shopping, Eswatini, go also shopping, medical care, we also do that. Namibia, we all almost every day travel to these countries. And like he said, if we put our resources together, we are saving our own people. We'll look at capacity, what do we have, how can we help? At the end of the day, if we have agreed on a protocol, let's ensure that that protocol will be implemented. Thank you for that. And also, maybe just to share with you, there's a journal that has been written by one of our senior lecturers at our medical school in Botswana, Dr. Mutsumi. If you want to Google that, you can. It was published in the African Journal of Emergency Medicine, where he did a study, when they were doing biopsy of people who passed on from RTAs. They realized that 68% of those deaths were preventable. 68%, they were preventable. And out of those, 45% of those happened after the pre-hospital care. Happened at the hospitals, where you thought, okay, we are able to beat the golden hour and save this person, and later on, because of our systems and all that, I think it was really an interesting paper when you come from trauma management and case management to look at. So really it's showing that we are losing lives that we are not really supposed to lose. Are we going to allow that? You could be part of the statistics tomorrow. So if we don't work on our systems, we will really exposing everyone to undesirable outcomes that may happen. Thank you for that, Patrick. And with that, my sisters that side, Lynette, maybe I'll start with you. From our experiences from case management, I just want us to discuss how can we measure the return on investment of the integrated care initiatives that we are talking about, and what metrics matter most to funders or policymakers. Go ahead, feel free to stand up also, or you can do it
Yes, the
sitting
pressure.
down.
There's so much pressure with our lecturer colleagues here, forcing us to also stand up. But yeah, thank you very much. I'm Leonie Meyer, and I'm an occupational therapist at the Road Accident Fund in South Africa. And case management is my passion, and disability is my passion. And you know, in these sessions, pure admiration for this conference, pure admiration for the ministers being part, pure admiration for the integration, because when we talk integration, it's a dual approach. Whilst we talk integration here, integration needs to also happen on community level for this integration to be successful. Because like you say, I don't believe there's more protocols anywhere else than in the road accident funds. Protocols and policies in the road accident funds. But I must admit that I do have one small criticism for all our road accident fund conferences. And if you don't mind, the disability community says nothing about us without us. And I sit at conferences and they always come and they fight for disability rights. And are we really listening as the road accident funds? Because I don't see a single individual that has a disability from the community as part of these engagements. I think that is just something that comes up in my spirit, that going forward as the road accident funds, we need to start considering. You guys are doing an amazing job inviting Department of Health and the Finance Ministry, because that collaboration, integration is important. But like we said, we need to take it down to community level. I think for myself, as I grew up in a poor socioeconomic community of Bishop Lavis in South Africa, I wonder if I've forgotten what it's like. I sometimes wonder if us as leaders, if we've forgotten what it's like to live in a rural community. I wonder if we sometimes forget what it's like to be poor. Because if we've forgotten what it's like to be poor in a rural community, then we definitely won't understand what it's like to be disabled after a motor vehicle accident in a rural community. And I think that's where we need to place our focus. We need to start generating outcomes for the disabled victims of road accidents. And if I look at the numbers here and I compare, like you say, to the numbers in South Africa, we probably have over 200 deaths per day with road accidents in South Africa. So the problem and the devastation that goes with accidents are real. But what can we do? So whilst we need to develop an understanding of the real challenges, I'm also a PhD student, and part of my research will be to conduct interviews with road accident victims and understand what is it that they actually need to successfully reintegrate. And for me, that's a key outcome. We need to have outcomes, real outcomes. How many disabled motor vehicle accident victims are employed gainfully? That's an outcome that we should be working towards. How many of the road accident victims in poor socioeconomic communities are running a successful business? Are we just becoming used to seeing our disabled claimants being poor? Are we used to seeing them feeding off the RAF system? Or are we actually placing mechanisms in place in the communities for successful outcomes? How do we redefine our offering? How do we change from a compensation model, we are here to claim from you, to actually implementing a model of care? How do we make sure that we deliver OT and physio services as part of the package of the claim, so you have immediate access to the care that you desperately need, not just the money that you're going to blow? So what are the outcomes? The outcomes are in terms of patient reintegration. The outcomes are in terms of employment. The outcomes can be measured in terms of their satisfaction, in terms of the services that they receive. So yeah, I think whilst we are here, it's important to have these engagements. It's important to have the discussions. But as an OT, I'm a practical person. And I want to be able to look at someone who's been in a car accident. And I'm saying to myself, if we look and we should do research and we should follow a claimant who's been in a car accident, who's got a medical aid and a good social support system, and we should compare them to someone from a rural community who's been admitted to a public hospital with the same diagnosis, and we follow them for 10 years. What does that outcome look like? What is the difference? For me, that's where the answer lies. That is where our responsibility lies. That is where we need to start zooming in to see and stop just accepting that the person without the care, that the person who lives in a rural community is destined for unemployment. There's an opportunity for us to change that. So thank you.
Thank you very much, Leon. Thank you, and apologies for calling you Lynette. Thank you. That was so powerful. I think, really, ladies and gentlemen, the disability, we are really disappointed in the disability community. When she was talking about this, I was just thinking about the pamphlets that we have on road safety, on products and services. I'm thinking about our social media pages, and I'm just wondering how many of these are accessible to everyone. Can a visually impaired person access this information? Yeah. So let's think about that. Do we have these documents in Braille? No. And which community are we servicing? Only the able-bodied? So let's really think about it. Because as she's talking about this, that, when we talk about outcomes, this really should be meaningful to the person you are giving the service to. If you talk about returning somebody to work, if you talk about successfully running a business, if they cannot access the information that they need, like everybody else, to run a business, to establish a business, we are really failing this community. And we are talking about inclusive healthcare. We are talking about universal healthcare. So I think my take home from Leon is that let's ensure the vulnerable communities are able to access all this. Then we can talk about the outcomes. Thank you very much, ma'am. And my sister Eva, as she was talking about reaching all those people in the rural communities, faraway places, I'm just thinking about some of the things that we can leverage on. And I'm thinking from you, let's talk about digital platforms. What role can mobile applications or telemedicine play in post-accident follow-up care, especially in those faraway places? Let's talk about telemedicine, telerehabilitation, all this technology that is coming up. How can we leverage on that? Thank you.
I think I have to stand up just to follow. Yeah. Thank you, Lydia. My colleagues talked about how we can reach our clients that we are serving, and we are now in this time whereby technology is enabling us, and we really need to make use of what is available. Yes, we appreciate that most of our clients are from marginalized communities, and as us as funders, we have to look at the ways how we should make sure that our clients have access. So the accessibility should make sure that we enable our clients that we serve, that they have access to the available technology that we have. As case managers, we need to make sure that our clients are able to have access to the information that will enable them to take center of their rehabilitation journey. Looking at still at the population that we are serving, it is high time that our budget, when we are budgeting as funders, let us make sure that we create that environment and that platform that all our clients, irrespective of their background, are able to access the information themselves. We know exactly that, look at the number. Let me take an example of Namibia. We have 14 case managers that are required to serve more than 5,000 clients. And then by look of things, if you have now to go client by client, you might not be able to reach each and everyone. So we have now to make sure that can us as the funders develop a strategy to make sure that telemedicine and technology becomes part of our operations. Thank you.
Thank you very much. Thank you, Eva. I totally agree with her. Every fund needs a strategy on telemedicine. We cannot reach all of our clients at our desired times. So we need the assistance of whatever is available. So we really need to see strategies like that. In your strategies, Tenji, as we work on corporate strategies, we need to say that the funds have been very, very deliberate on how they're going to reach clients that they cannot physically reach, because technology is here to help us. And as we do that, remember, also this technology has to be accessible. This technology needs to be accessible. I've seen a lot of applications. Accessibility is lacking. Some of it, of course, is limited by our knowledge of the gadgets that we have. I will not say the gadget that I'm using, but I've realized some people with the very same gadget, they don't know that it has the functionality of accessibility. To make it accessible, whether you are hearing impaired or visually impaired, they underutilize those functions. So unfortunately, because we want them to be able to fully utilize this, we have the responsibility to teach them. We need to find ways of making sure they know they can access these things where they have those gadgets. So as number one, we need within our strategies to be deliberate and intentional and say we are going to have an objective on that. Those people that need us to go an extra mile to make sure that they also access the benefits like everyone else. Thank you, my sister, for that. In the interest of time, I'm just going to ask my panelists to take a minute to just share their thoughts and summarize their thoughts. The host, I don't know if we have an opportunity to have 2 or 3 comments from the floor. Okay, my panelists, sorry, before you summarize, you can think about your summaries while I allow 2 or 3 people to comment. Thank you very much. We have the first hand here. Thank you, sir.
Thank you so much. I'm Sabelo Masugu, and I'm from Eswatini.
Thank you, Honorable.
Just a comment on the pedestrian cases. We saw what Dr. Ngube projected there in terms of the statistics generally, looking at the other countries. If you travel to Europe, pedestrians there are kings and queens, if you like. Well respected. I mean, perhaps that is why the numbers were low there. But to the contrary, I'll speak about our country here. Pedestrians are considered a nuisance. I mean, it's not unusual. Let me stand up. So, so it's not unusual, for example, to see someone blowing his horn at a pedestrian crossing line. Get out of the way, or road raging, and simply forgetting that once they switch off the car and get out, they are also pedestrians. Now, so what we don't also realize is that once you are a victim, doesn't matter whether you're a driver, passenger, or pedestrian, it's just like that. So it means even if you're a driver, don't think that you are safe where you are. I think we need to actually, call upon our stakeholders to teach the nation on the road spaces, emphasizing on pedestrians. I think there was a very good example of us at primary school those days. Really, we went to rural schools, but there was always an exercise, one way or the other, in the morning on Tuesday, when you know, if you are a good boy or good girl, you'll actually have this privilege of holding up the stop sign with the teacher and have control of the whole class. But figure this out. The roads were dead roads. They were not even pedestrian roads. We could just imagine. We were seeing the pictures of pedestrians, that the pedestrian crossing zebra line, so to speak. But we never really, knew exactly what it was. But we were able to grasp that. So I do believe that the education side is very key. Also, you are talking about fines. I think there's got to be a way in which we can lobby our legislatures for steep penalties if you harm a pedestrian, even more than the drunk drivers. So name and shame, list them as road use offenders that are reckless with no care to pedestrians, something like that. Then a huge fine that we will impose at the courts. Thank you.
Thank you, Honorable. Thank you. I think really we are very much aware. We also have a problem of pedestrians. And for the past 2 years, it has got worse and worse, where people are just hitting and killing pedestrians. And from some of the information that we read, we know European countries, Netherlands, how they're doing very well by reducing the fatalities. And their strategies, two most important strategies, I think that's what the Honorable was talking about: education and penalties, how they're being fined. Remember, when you hit a pedestrian, that's it. You can never take a person to the garage, but you can have your vehicle back to how it was. But the person will never be the same. So they're very strict on that. When you hit a pedestrian, you'll spend a night in jail. So nobody wants to spend a night in jail, because tomorrow SMVAF will say, because you were in jail, that's it. Us and you, we can part ways. So once people know that the penalties are that strong, so nobody will be hitting a pedestrian. So maybe that's where we can start. There are certain strategies that they use. Vision Zero strategies is one of the mostly used strategies. I'm sure Patrick knows about that. Vision Zero safe system approach. That is one thing that the Europeans are really big into, and we have seen how it has reduced the fatalities on the road. We have 5 minutes. Do we have any other comments from the floor? Okay. 2 comments, Sebastian, and then Ms. Shonge. Then I'll take it back to our panelists. Yes, Sebastian.
Thank you. I don't know whether I should also stand, but yeah. Okay, let me follow the protocols that was laid already. My name is Sebastian. I'm from the land of the brave, which is Namibia. Just wanted to add on what Honorable said. You see, I think our lawmakers, the more we focus on the drivers only, we are actually fueling up the pedestrians. What I'm trying to say is that we are motivating them to say that it's only the drivers that are always at fault. They are not at fault. Now, there is a mentality of pedestrians where when someone is crossing the road, they know that the car is very close. They probably didn't double check. But in their mind, they are saying the driver can see me or the car can see me. But that's a car. It doesn't have eyes. There's a driver. Now, a driver also can lose focus at some point, because suddenly you are seeing a person that is in the road and it's at a shorter distance, you can also panic. I think when we are making laws, let's also look at penalizing pedestrians also. If you are found crossing at a not a designated pedestrian crossing, you should be penalized. Because as much as the driver is supposed to take care of you, you should, number one, take care of yourself and also take care of the driver also. And also, one thing I've realized, like back home in Namibia, school kids, what they do is that just because I don't want my shoes to get dirty, because I want them to shine when I get to school, I'll opt to walk on the tight road other than walking on the shoulder of the road. Now that causes problems for the drivers, because now you need to make sure that you are looking out for other drivers and also the people you are sharing the road with, whereas the road is meant for vehicles. I thank you.
Thank you very much, Sebastian. He has brought a very important point. The urban design for safety. How do we design our roads to make sure these kids, yes, I don't want to get to school with dirty shoes, but did you provide for me? Where are these kids supposed to walk? Right now it's a rainy season. Do you want those kids to be walking on the muddy puddles? So road design, cyclists, we also have a problem where cyclists are being hit in Botswana because, you know, even in today's modern road designs, we don't see cycling lanes, we don't see pedestrian lanes. We're now even promoting, you know, returning people with disabilities to work. We have more people on wheelchairs going to work in the mornings. Where do they ride their wheelchairs? So those are some of the things we need to think about. Really, urban design is very important. Ms. Songa, I'll let you comment. Thank you, Sebastian.
Thank you so much, Lydia. Good afternoon, colleagues. All protocol observed. My point talks to the lawmakers. In the country, we recently witnessed a situation where our lawmakers were able to close down drinking spots around the University of Eswatini. We all witnessed that from the time it resumed up to the end. I think it will have an impact if our lawmakers may also consider, we have seen a mushrooming of drinking spots in our rural areas. There are a lot of drinking spots in our rural areas. I don't know about Namibia, Botswana, and RAF, but locally they're just mushrooming. Back home, where we are complaining and presenting that even the health system is not so good, where the ambulance might even take more than 8 minutes to get to evacuate the RTA survivor. There are drinking spots there. We are talking about pedestrians. They drink, then they have to walk home. So we need to consider that as a country and control that aspect as well. Thank you.
Thank you, Ms. Shonga. Thank you very much. Yes. Really, this is a multifaceted problem. And we need to bring everything that we have, integrate everything that we have to make sure we don't predispose our people to injuries because we don't have the resources to give them service once they are injured. So especially rural areas. I also don't know whether it's because in rural areas we don't have much job opportunities, so we spend our time drinking. I really don't know. I know there will be other conferences on social protection that can discuss that further, but we are seeing alcohol problems going up, and we are seeing RTAs associated with people who were drunk. So really, we need all our stakeholders together to make sure that people are safe. I don't see any hand, and I'll start with you, my sister Eva. Let's summarize and your last thoughts summary about what we talked about, what you talked about, and where do you want to see us going?
Thank you. What I just want to say is that we have good policies in place. And our alignment to the convention, to the international instrument, give us that opportunity or that platform to deal with people with disability, of which most of our customers or clients that we serve are. So my take is that, yes, my concern is mostly, specifically on infrastructure, especially on accessible public transport in rural areas where our clients are. Yes, we are talking about technology, but if you can communicate, but you don't have a means to take you from here to where you need to get the service, it's really a frustrating, or is really a very difficult situation. So my request to the politicians, policy makers, is that we really need, as governments, we really need to look at accessible transport everywhere, so that all our clients, everybody who's having disability is enabled to move from point A to point B and participate freely in any society activities. I thank you.
Thank you very much. Leon? Thank you, Eva.
Thank you very much. I just have a short wish list of 5 items that I thought I'd share with you. The first item on my wish list is just access to medical records from EMS and DOH, and this is specifically for us, RAF South Africa. I think there's a disconnect between us and DOH, and this would facilitate seamless claims submission. We shouldn't be fighting for medical records, and if we have access to the medical records, we could issue and assess and finalize your claim with objective medical information. The second one on my wish list is case management and early intervention to carry claimants through, and we are actively involved in placing our case management, not just in public but also in private hospitals, to help claimants from the acute phase through to full recovery and successful reintegration. Third wish list item is a competitive claim system with a quick turnaround time incorporating AI. AI is the thing happening at the moment. Yeah, we shouldn't be struggling with claims. A road safety mindset shift, where as a country we learn to slow down, not just in terms of our driving speed, but also how we live life, learning to appreciate our own health and purpose, and setting an example as road accident fund employees. That's important for us to learn just to slow down, not just our drivers on the roads, but we generally rush through life and we don't appreciate what we have enough. And then my last one, I think preferential medical care. I like the one on the pedestrians being funded or fined. I think it's time for us to start thinking out of the box. The world is moving at a fast pace, and I think if we look at the devastation that goes with accidents, we need to start doing things differently. So preferential medical care for disabled MVA victims and equal opportunities and access to services in communities. Thank you.
Thank you very much, Leon. I think really sharing data is really critical to us succeeding. And I think I'll have to thank the management of the funds for allowing us to be coming together on an annual basis to share this information, because really it's critical to what we do. As Leon was summarizing, I was also thinking that Well, in Botswana, we have the Data Protection Act is quite new. I know you have had it for quite some time. So these are some of the things that we need to be thinking about. We want to share information, and then there are some limitations within our legislations, Data Protection Act. Let's see how we can bring everything together and make sure that we are still within the law and we are able to share that information. The use of AI as well, it's a big thing, like she said, but also cybersecurity. Cybersecurity. We are so, all of us, vulnerable to those ransomwares. So let's make sure as we do all the best that we can. Even though I was talking about technology and technology, I'm one person who is crazy about technology, but we know that the hackers are also working 24/7. Let's just make sure that we are aware of that. Dr. Chabalala, please give us your last word. Thank you very much.
Okay. As I'm sitting down here, I'm looking in this house and I'm saying, by the way, what is disability? And I look at each and every desk. On average, there are 2 people in each desk who are wearing glasses. Is that disability? I consider it disability, but I don't see myself as a disabled person, you know. Why am I saying that? Disability is an attitude. It is a label that we use to people who are not like us in some way or the other, whether mentally, physically, and otherwise. As I was standing up, I was struggling. A young person would say, Magogo is also already disabled, you know. So as we speak of the issues of access and inclusivity, let's also try not to label, because then it is stigmatizing. Once you feel stigmatized and discriminated, you coil back into your shell and not come out to actually seek what belongs to you. Coming back to the story of the day, I'm a keen avid liker of numbers, although I don't like Q times X is equal to Z. I don't like that. As my doctor here was presenting the statistics, he talked about the fatality rate, the fatality numbers in Eswatini as 200 compared to, say, maybe in Kenya that I know. I've been doing a case study recently, where on average they are losing about 2,933 people per year. I said, these numbers are very misleading. Why are they misleading? Because somebody will say there are more people dying in Kenya than there are in Eswatini. But if you convert that to rate, the rate in Kenya is about 5.03%, because they have a 58 million people population. Vis-a-vis in Eswatini, where we are losing 200 people in a population of 1.2. I mean, you are losing 200 people in a population of 1.2 million. And if you convert that, it's almost 17%. So if you interpret that in terms of analysis, you are saying in Eswatini, the chances of a person dying from a road crash is actually 3 times that of Kenya. That's how we should be looking at the statistics. If we're talking to Judge Masugu, if we're talking to the parliamentarian, I think that is how we should be expressing the numbers. Because they will say, 200, that's nothing. Yet it is a big number. I'm happy I was able to debate this case in another scenario where we're writing a proposal. Because what happens is that in these proposals, particularly when it relates to road safety, you find that most of the money goes to the countries up there, East Africa going up. And I was like, why is that the case? I said, no, we're looking at numbers. And I'm saying, what do you mean by numbers? No, there are many people dying in Nigeria than there are in whatever country they mentioned, Lesotho or what. And then we went down to say, what does this represent in terms of the population in that country? So I'm just saying, as we do these numbers, let's also look what does it mean when you then put meat in those numbers. Coming to the issue of the story today, I think for me, education is key for us to actually change the status quo. People must know. People must be educated. They must be given the ability to take charge of their health, of their ability to cross, to use the road. But as well take charge in assisting the next person use the road. Because if I know how to use the road better, I will limit the chances of, I'll make an example of Judge Masugu hitting me because I have taken the precaution, because I know, you know. So education for me comes very critical. But then how do we translate that education? We must understand that there are people who wear glasses who may not see small letters. There are people who may not hear as I talk. There are people who may not hear and read because of their disability. Let's make it possible for them still to receive that information in whatever way is possible. It is also very particularly important to make sure that our road infrastructure allows every road user to have the ability to use the road and use it safely. There have been examples that have been made about Europe. Europe, as he said, the pedestrian is the king. But in Eswatini, it is not the case. In other countries, it is not the case. I have seen a little bit of it in South Africa when I'm driving there, and I see people stopping for pedestrians. It is in the law, I think, but we are not enforcing it, which brings me to the next point. Okay, making the road, let's make pathways for people to be able to walk freely without mixing people and cars. As long as we do that, there will still be accidents, particularly to pedestrians. Let's make sure that we have the laws. And once we have the laws, let's enforce them. The laws must not have eyes. They must be very blind. Judge Masuk, they must be very blind. I know that you are one of the people I can safely rely on when it comes to such issues that are taken to court. But I know that your colleagues probably are not, because they are themselves the perpetrators in some cases. They come out of court, they are very tired. I'm making an example, by the way. Please quote me, media, please don't quote me. They come out of the court, they are very tired, they've been dealing with a very serious case, and they feel like they want to take 1 or 2 buckles, and then they go into the road, you know, and they hit people. So let's enforce the laws that are there, but make sure that we also revise those laws that aren't biting enough to actually deter people to do the wrong things. Let's make sure that we provide or are provided with the resources. I don't believe we don't have resources. They may not be enough, but they are there. But it's just that each person is using their resources in something that someone else is also doing and using their own resources. Why not pool the funds together and say, we have Ministry of Health, they have something on the subject matter that they are funding. We have something from MVA. We have something from Ministry of Education. We have something from there. Why can't we pool the resources together and see if we can't make a difference? Than to say, I will do my own, I will do my own, I will do my own. That is, for me, a wasteful. So as we talk integration in this conference, in terms of case management, the integration must start here with us. Let's work together in terms of the resources, human, in terms of resources, financial, in terms of the resources, whatever. If we pool those resources together, we can go far if we go together than when you go alone. We can be able to achieve this. Maybe my closing remarks is to thank everybody here for listening and for paying such attention. Where I didn't say right, it wasn't intentional, but I had to say it. I cannot say I'm sorry because we need to talk about it. Thank you.
Thank you. A hand of applause. Thank you very much. You just reminded me of the the saying that people with disabilities always say. And they always say, you know what? We believe we are not disabled, but the environment is disabling us. So really, sometimes it's us disabling them, not allowing them to walk through that door or wheel their wheelchair through that door when they can easily come through. So these are some of the things really that we should be our take-homes. And the issue of education, I know we always talk about education, and I'm happy that you said it 3 times, education, education, education. And I just want to say, I don't know what is your experiences, but I'm not opening it for discussion. We did a road user, road user behavior study a few years back in Botswana. And you know, when you assess the level of awareness, it's at like 99%. But Africans, the practice is totally different. I don't know how we can solve this one. I don't know whether it's still the laws, honorable, if they can help us. Another example from Botswana, you know, our discussion about death penalty. I get like everybody's aware of Botswana's stance about death penalty. But people are still killing each other. So the law is there, the enforcement is there. People are being killed for killing people, but they're still killing people. So really, I don't have answers, and as I was saying, I'm not opening it for debate, but we Africans, we know everything. We just choose not to practice. Everybody knows how the car can kill someone, but we can just drive through a pedestrian cross when a pedestrian is crossing, or as fast as we can by the school when we know children are playing outside. So those are some of the issues that unfortunately we need to do more than what we are doing. I don't know what it is, but we need to stop this accident. These are preventable and unnecessary deaths. Right now, road accident is #1 killer in Botswana for the youth, for the working group. I don't know, even here, #1 killer, followed by HIV, but imagine this is preventable. With that, Patrick, what will be your final word? Thank you.
Thank you, Lydia. I think 3 key messages for me, and to challenge case managers in the conference as well as institutions of higher learning. Why are we seeing what we see? That's a research question. Why are we seeing what we are seeing? We really have to come up with concrete answers because we need to be evidence-based. Why the increase in pedestrian accidents and deaths now? If we answer that question, we then develop strategies that are appropriate to address the occurring or the recurring challenge. If we then are going to say maybe it's this, maybe it's that, then we're not going to guide the legislatures, the judicial to come up with a strong legislation for us. So that's one key message. Number 2 is the case fatality for us here in Eswatini is high, definitely high. And our target is to halve that by 2030, which is 4.5 years or 4 years, 3 months down the line, by 2030, of the targets that we have set. So 17% divide by 2 mathematicians here. By 2030, we should be at around about 8-7% or so. Is that possible? It is possible. So if it is possible, let's clap hands for ourselves. That's a key message. Let's clap hands for ourselves for that. Lastly, Chair, we really appreciate that this regional conference can be also hosted here in Eswatini, because it gives us an opportunity now to understand that we can innovate and integrate and collaborate, particularly taking advantage of innovation and existing new developments that are taking place within Eswatini, across the region of Southern Africa. So it's an opportunity for us to strengthen our emergency care, in particular because some of the deaths are preventable. If they are preventable, answers, the next generation are looking for answers to this generation. So you are the generation. Thank you.
Thank you very much. Thank you very much, Patrick. Most importantly, as he was closing, research. I know in our last conference a year before, was it 2 years back, Mazel, in South Africa, our theme was about research. We all need to be informing our strategies. And I know we are doing the little in our little pockets, we are doing as much as we can. But, you know, hypotheses on an annual basis are changing. We used to think that using the cell phone in the cars, you should not hold your cell phone while you are driving. But now more information is saying is the conversation, not the holding of the gadget. So if you are still going to be putting it on Bluetooth and drive distracted because of that conversation, really, these are the things that we should be prompting on an annual basis to say, okay, last year we said this kind of education will help. Is it still working? My son totally understands the world in a totally different, like 180 degrees different from how I see the world. So if you are going to talk to them, you know what the youth say. They say, when you tell them that don't go out at night and drink and have a good time and make noise in the car and drive and all that, because they will say, why? He said, you will die. And they say, you know, sometimes it's better to die when you are doing something that you are enjoying. So imagine dealing with somebody who is saying that. How do you deal with somebody who thinks of the risk that way? To say, you know, if I'm going to die doing something that I love and enjoy, it's a better death. So they'll say, you will die sitting in your living room, mama. So I'll die having a good time. So think about these things. So really, that's why we need to continuously research. How do we reach these people? How do we make it matter to them? Because we are losing them. We just had an accident, I think 2 weeks ago. Age ranges were 21 up to 27. There were 4 fatalities. So young people perishing like that. So thank you for mentioning that research. We need to be researching. The next conference, Namibia, Eva, we need to present our papers. And he also talked about the targets, Decade of Action target. I think all of us have been signatories to that, those United Nations. And really, when you ask me, are we going to have the number? I don't know. Botswana, really, I don't know if we'll be able to have the numbers. It looks like Eswatini said, yes, we can do it. I wish you all the best. With the behaviors that we are seeing on our roads, really we need God's intervention. Amen. I'm going to close this session. And by closing, okay, I tried to I tried making a summary of what we're talking about. And before I do that, I'm going to thank you. And at the end, I'm going to thank you again. As we wrap up the discussions, it's clear that integrated care is not just a clinical concept. We have seen how it's a moral imperative, a technological frontier, and a regional opportunity. This is our opportunity to talk about it and say, how best can we do this? The insights shared here today, thank you, my panelists, they remind us that collaboration across borders, across sectors and disciplines is essential for building a system that truly serves everyone, especially the most vulnerable that we are talking about. Let's carry forward the momentum from this dialogue into action, implementation. Through policy, innovation, and shared commitment to equity and excellence in care. Let's remember better outcomes should be claimant or patient-based. Their feedback of what they think is better, that's what matters, not what we think is the best. When a mother says, when you start interviewing a mother who is injured in a road accident and they say to you that my goal is to be able to wake up tomorrow and bath my kids and take them to school. That is the outcome you should think about. As you rehabilitate them, don't say I'm rehabilitating you so that you can go and play sport and think about what they told you. I want to play my role as a wife, and that is their goal. And that is what's going to motivate them to participate in their rehabilitation. Keep reminding them of that goal, that they want to be able to bath their kids and take them to school. That is the better outcome. That is a patient outcome. And finally, thank you all for your contributions. And let's all hold our hands as we go through this transformative journey. As the SMVAF funds and all our key stakeholders, we thank you very much.
Ladies and gentlemen, let's give them another round of applause. I know a lot has been said here from sharp minds shaped by experience in their different fields, winning the battle sometimes, losing at other times, but always endeavoring to do best for actual and potential patients. Thank you very much for sharing these ideas with us. Every day, we don't only experience what we see on the road, but we also learn from practitioners who get to deal with these people for the longest of time whilst they are writhing in pain in the hospital beds and the hospital wards. My sister there, Ngeti, helped me to mess the program a bit. And it was accidentally on purpose, because we realized you people were about to fall asleep. And we just shook the cup a bit to say, our guest speaker, Dr. Ngube, will come after the panelist. He also has learned one or two things about pedestrians. And Sebastian, my brother, you are spot on. Just last week, the early week, the road myself and Dr. Shabalala use when we come to work realized another fatality. Apparently, a group of drivers were competing for customers early in the morning, just before 7 o'clock. One was taking the road to Manzini, and the other one was going back to our village in Tabamtloshana. So this one had something to give to another driver going up there, and the two were competing. So he stopped his kumbi and became a pedestrian and crossed the road. Seeing that the kumbi that was approaching, or the minibus that was approaching, was driven by a fellow friend. So he thought he would stop, and even raised his hand just to indicate that it's me, friend, stop so that I cross over. The friend was in a haze because he was rushing to outsmart the very same kumbi that had been stopped by this guy. So it just ran through him. And for about a good 50 meters, he was holding him on the ground. It's a case that is in our laurels now as a fund. The pedestrian was at fault, the driver was at fault. So is the situation with many pedestrians and drivers. It's a sorry sight, it's deplorable, and it's painful. So we need to bring an intervention that's going to hit at both. Whilst we decry negligent driving, but we are also shocked by the nonchalancy of drivers, of pedestrians on the road. Remember the road, there are so many variables into this pedestrian hotel. The road is inundated with informal markets close to the road. At any time, somebody is going to cross from this side to the other without giving much attention to the oncoming motorist. And for a country, for a homestead in this country to be successful, it must be by the road. Some of our good roads have just a number of homesteads just on the peripheral of the road. So when the parents are not there or the cat is away, mice are apt to come out and play. Those are our children. They'll be playing on the road, sitting on the guardrails, kicking the ball on the streets, and they are injured. Nobody wants to have or to erect a house somewhere up the mountain and look yonder down the road. They want to be on the road. The road reserve, it's suffocated by beautiful houses whose children spill out onto the road and expose themselves to such things. So the pedestrian issue, Dr. it's an issue or a basket of many variables. And if we lift one by one, we realize we need a very vigorous intervention to confront it. As of now, we are trailing behind 5 knot. Dr. Ngobe, I have the podium for you with the powers vested on me as a host. Before I release my congregation here for lunch, I can be a pastor if I can choose Dr.
Thank you. Thank you, host. Good afternoon. My name is Dr. Thando Ncube. I'm an orthopedic surgeon. For the sake of brevity, please allow me to write on the observance of protocol that has been done. Thank you. It's a great privilege and honor to present. It's deeply humbling, and I really don't take this responsibility lightly. Thank you. So the purpose of this presentation is to demonstrate how a unified approach improves patient recovery and system efficiency. Now, that's the literature which we quote when we're discussing the scourge of motor vehicle accidents. MVAs are the leading cause of disability, and these figures are quite compelling as they show the magnitude of the problem. At the bottom of the slide, we see that 90% of global MVA deaths are in low and middle income countries. Yet, only 60% of global vehicles are in those countries. So that's quite a lopsided statistic. In Africa, the cost of MVAs to our GDPs ranges from 5 to 8%. And to put that into perspective, NATO nations have pledged to spend 5% of their GDP on defense spending. That's an intentional reason for them. And yet this is unplanned spending. That's quite significant. If we compare to developed countries, UK, Australia, Canada, and Germany, the cost of MVAs is roughly 1 to 2%. We also bear a huge brunt of the fatality rates. Zimbabwe being 35 per 100,000, South Africa 20.7, Namibia 23 per 100,000. Yet in the Northern Hemisphere, the UK 2.6 per 100,000. Germany 3.4. So our fatality is almost 10 times. The MVA victim is a very complex patient. There's a constellation of injuries. It's not only bones, it's the head, the thorax, the abdomen, but as well as the mind. There's post-traumatic stress, there's depression, anxiety, and the effect on the pocket. Now, the traditional care of patients is that the patient is at the center of it all. He has to go to the ER, he has to consult with ortho, consult with rehab services, neuro, and the pain clinic. And that's a disjointed kind of setup, which leads to delayed consults, fragmented communication amongst those experts, redundant testing, and we miss the psychosocial needs of patients. So the current reality is that the care is episodic and uncoordinated. Now, the goal of integrated care is for us to get better outcome. A better outcome is not just a healed fracture. It speaks to successful return to life, and the solution is integration. So now, as we discuss the integrated model, we look at the multidisciplinary team approach to patient care. The core concept is that the case manager is pivotal to this seamless team. Excuse the size of the font. In the middle there, we've got the case management being at the center, surrounded by all complementary services, orthopedics, critical care, physiotherapy, trauma, and as well as psychological services. So in the acute phase of the injury, integration should start at the moment of arrival of the patient, or at the moment when somebody gets injured. Now, in the subacute phase, this is where patients often fall through the cracks. And the case manager is the glue that connects the hospital to post-acute care and community services. So our focus should be seamless transition to rehabilitation. And as I have said, the key elements are dedicated case managers, early psychological screening for PTSD and depression, and we shouldn't forget about proper pain management strategies so that we avoid the opioid epidemic. The case manager plays an important leadership role because they've got a unique position in that they can see the injuries start right up to the functional end. And therefore, we must advocate for long-term function and not just short-term function. So in this slide, these are the roles of the case manager. Holistic care, they lead it. They coordinate the execution of surgical care. They play a role in the long-term functional oversight. They coordinate specialty consults so as to avoid disjointed patient care. The case manager has to champion the multidisciplinary team approach in the institution, as well as after discharge. The case manager also plays an important role in the management of the financial resources. And lastly, they play a role in issues of redress, issues of compensation. So that's quite a very pivotal role. And yeah. So here I'm now looking at the key areas where we need to integrate care. And I've identified that physical and mental health need to be integrated because there's a high incidence of pain and post-traumatic stress disorder and depression in MVA patients. The solution should be mandatory pain clinics, psychological and trauma counseling referrals, and that should be started very early. Screening tools can be used. I'll not elaborate on that. I'm not a psychologist, but they can advise. This slide, this arrow starts from the top or the peak of pain. And we need to go down to minimum or no pain. The benefit also being that, the goals being that we should have a reduced opioid burden. So essentially when we manage pain, you have to start with preemptive analgesia. Don't wait for somebody to complain of severe pain before treating it. When you wait for pain to start and it's severe, it etches a mark in the brain, in the memory, and that has long-lasting effects on the patient. Regional blocks, multimodal regimens, they all help to minimize the need for opioids. Opioids are addictive. After discharge, pain clinic referral, and you can still continue with the regional blocks, multimodal treatments, but not forgetting the psychosocial support, family as well as psychologists. We have already touched on the role of technology and data, and the colleague from South Africa in their wish list mentioned that if there could be ways of sharing electronic medical records, that would really be beneficial. It got me thinking when I was doing my my master's dissertation. I had to page through lots of medical records, and quite a number of them were missing because they'd been taken by the Road Accident Fund. But I'm sure the Road Accident Fund also needed those files, and they were with me. But if there could be ways of scanning documents or just simple electronic medical records that can be shared everywhere, it will reduce that dilemma. We can employ the same for telehealth and follow-up and rehab. Nowadays, we've got the smartphones. WhatsApp is a good resource. There's also an app which was launched in South Africa around about 2017. It's called Vula. It links medical practitioners throughout the country. And in October, they reached a landmark milestone of that. They've got 2.5 million referrals that have been done through the app. we need to coordinate the external systems. In the first point, I discussed the insurance or funder communication. The MVA funds need to have good discussions with funders, because maybe one day funders may want to abdicate their responsibility of handling or paying for trauma cases. And those are discussions which need to be had between MVA funds and medical aids. In that coordination, case managers will link the patient to the legal resources, as well as vocational rehabilitation. This is quite an interesting area, medico-legal environment, but I'll not pontificate on it. I'm not an expert, although I'll offer a personal medical opinion on this legal environment. So the elephant in the room is that the legal process itself is a major cause of stress that can impede healing. It creates a state of uncertainty and the need for the patient to repeatedly validate their pain. Research has shown that an association between involvement of litigation and compensation with poorer health outcomes. Whenever there is a case where money shall be paid after, patients tend to have chronic pain. They tend to be in psychological distress, and they don't return to work as soon as they really would. And therefore, there is that negative feedback loop between the legal process and just the physical recovery. The role of the doctor, our primary responsibility remains to the patient, but documentation serves as a medico-legal function. Our role is to be fact-based medical advocates. Thorough, objective records are the foundation to a fair claim. Accurate and timely documentation needs to be done so that you can link the injury to the MVA and as well as the compensation. You need to establish causation and therefore provide an expert opinion between that MVA event and the long-term symptoms. There is the concept of maximum medical improvement, which is employed when we determine the impairment as well as the disability of that patient. That's where we come in. We need to carry out functional assessments, and our reports need to emphasize on functional limitations, but not forgetting the future care needs. The role of the case manager is to insulate the patient as much as possible from the procedural stress. The integrated model helps streamline the compensation process by providing a unified, consistent, and credible medical narrative. So I'll emphasize again that the case manager plays a pivotal role in that whole administrative process. Case managers need to be very astute when handling the patients. I will give a case presentation of a real patient where that astuteness has come to the fore. Our first case, we had a 47-year-old male. He's a cattle header. He was hit by a car whilst he was on the side of the road looking after cattle. This injury happened about 2 years ago, 2023. Sustained a distal tibia fracture. As you can see on the x-rays, he was treated in a plaster of Paris. The alignment was not good, and therefore the fracture malunited, as you can see. He had surgery 2 years down the line. He had to break the bone, realign it, and bone graft it. The bone graft you take from the side of the pelvis, and there's also some artificial bone, which is quite expensive, that you put into that fracture. So the pitfalls immediately is that this is a prolonged procedure. If this procedure had been done right from the outset, it can take 40 minutes or an hour with minimal blood loss without the need for bone grafting. But when it is done at this stage, definitely the costs, financial costs, are twice or thrice. But again, the risks to the patient, taking bone from the side, putting foreign bone into the patient, that's quite significant. And therefore, this case, the recommendations should be earlier intervention. And this is a patient who had slipped through the cracks in a state institution. We need to empower the state hospitals. Second case, 60-year-old male, again a pedestrian, August 2024. A car ran over his foot. He had an open wound on top of the foot, which was sutured. And then he came to see me complaining of low back pain, which was radiating down the leg, right up to the foot. There was no swelling in the foot, no sinuses, no pus draining from the foot. The X-ray of the foot showed a healed metatarsal fracture. An X-ray of the spine was done, which, that's a side view of the spine. And these are the vertebrae. Of course, the pointer is not, yeah. But you can see the vertebra, and the space between this one and that one is quite narrow compared to the other levels. This gentleman said the foot pain which you are suffering from is a result of the accident. But the diagnosis here is lumbar radiculopathy. There is compression of nerves at that level of the spine, which is causing pain in a distant area. So now you have to educate the patient and help them understand that this is something completely different and manage their expectations for compensation. So the question there which I posed to you, would you give a disability to this patient? The answer is no. Third case, 47-year-old female. This time it's not a PVA. She was involved in a combi accident, sustained soft tissue injuries to the legs. She said she developed a neck swelling in the back of the neck 2 months after the accident. She linked the swelling to the accident and she wanted compensation. On examination, that swelling was the size of a golf ball. It wasn't painful. It was a mobile mass. X-rays of the spine in the neck were normal. The diagnosis was a lipoma. A lipoma is a benign or a non-cancerous growth, okay, made of fatty tissue. So it's just coincidental that this thing developed after the accident. Or maybe not a coincidence, it was there before and they would want to ride on the compensation that ensues after these cases. So I wouldn't compensate, you have to educate. And I mean, to what extent would the fund go in terms of investigating and offering treatment here? I think the buck stops there. You cannot go further. Fourth case, 45-year-old male. Quite a touching one. MVA, June 2023. The fiancé deceased on the scene. He sustained a degloving injury of the forearm with associated injury of the nerves. He also had a fracture in the humerus at the level of the shoulder. This happens to be his dominant hand, and therefore this is quite, disabling. He's no longer working because of that injury. He became depressed and he was put on antidepressants. There is the X-ray showing a malunited neck of humerus fracture. With the way that bone is aligned, it restricts his ability to lift the arm. So simple things like combing his hair, washing his face, there's restriction. And then the paralysis in the hand, it affects his ability to write and type. Now, the pitfalls in this case, when I discussed with him, was those of delayed management. There was delayed referral in the mix. There was also lack of coordination between the different specialties that were treating this individual: orthopedics, occupational therapy, plastic surgery, psychiatry. He got it all, but at different points. Fifth case, 37-year-old female, got injured August 2024. She sustained lacerations to the right leg as well as the right periorbital area around the eye. In female patients that I've seen, this is one of the greatest cause of worry, facial lacerations. And it has changed the way that I manage patients. Whenever I have someone coming in with a fracture in the leg or the arm, and there are lacerations in the face, it's not my area to deal with that. But when I'm in theater, I will deal with the bone, fix it, and then go and do some nice cosmetic work on the face. Because when the fracture is healed, that complaint of disfiguring wound, scars in the face will always bother you, especially ladies. So an examination, she came complaining of knee pain this time. She was quite a big lady. There was a J sign. A J sign is a physical finding in the knee which demonstrates that the kneecap or the patella moves in an abnormal way. That patella was also unstable. It was moving abnormally, excessively. The X-ray showed patella alta, which is a high patella. And there was trochlear dysplasia, which is abnormal shape of the front of the femur. So that's the knee X-ray. A side view of the knee. This is the femur, the thigh bone, the tibia in the leg. The fibula is the smaller one on the outer side of your leg. That's the patella or the kneecap. So if you do some measurements, you'll see that this patella is high. And when you look very closely, there are some surrogate markers that demonstrate that this femur is abnormal in the front. This creates a situation where the patella is unstable. There's pressure on the cartilage in the front of the knee pain, worse with kneeling, worse with sitting for prolonged periods, worse with going up and down stairs. So this was a case of patellofemoral pain syndrome. The highlights for this case are that you need good documentation of injuries from the outset, and knee injury was not documented at the outset. Thorough history taking, examination, and appropriate imaging is important. And lastly, you need to educate the patient to manage their expectations. So she thought that this knee pain arose from the car accident, but this is a completely different entity. This is the last one. 56-year-old female involved in a car accident April 2022. She was seen in an A&E. X-rays were done, they were normal. I don't know what X-rays were done, but this is what she told me. She came complaining of low back pain radiating to the left leg, and that started a week after the accident. She was referred to a physio as well as a psychologist at the time. She had already been seen by an orthopedic surgeon and an orthopedic spine surgeon. An MRI was done. The MRI was done in August 2022, so that's 4 months after this car accident, and it already showed degenerative changes. Her spine was tender, neurologically she was normal. An X-ray was done and it confirmed the presence of degenerative changes, and critically there was no fracture or dislocation in that spine. So that's the X-ray. Again, it's a side view of the lower spine, the lumbar spine. If you look at this level, that's the L5 vertebra, L4, L3. The space here is narrower compared to the other levels. If you look at the front of the bone, it's more pointy. We call those things osteophytes, which are signs of degeneration of the spine. So the question here, there was a dilemma to say, are these symptoms post-traumatic or were they pre-existing? The pitfalls here were that I did not have any previous medical records right from the outset. And it then becomes a matter of conjecture to say, well, you're in a car, somebody bumps you from behind. It is highly unlikely that within 4 months you'll develop fully blown degenerative changes that are picked on an MRI scan. But the argument could also be said, yes, I've got my degenerative changes, but that accident worsened my situation. My disc slipped on that day. And you have to give the patient the benefit of the doubt, because I cannot prove the contrary. But that's not my area of expertise. I think his lordship should be able to, yeah. So in conclusion, the key takeaways from this presentation is that care has to be optimized, and it needs to be timeless. It has to be holistic. The mind and body need to be addressed. We should avoid fragmentation of the system, and that's where the case manager comes in as that glue which holds the team together. We also need to measure the outcomes so that we can do benchmarking, we can do planning, budgeting, justification when we ask for funds from the Ministry of Finance. The compensation process needs to be streamlined. As I've said already, that it's a source for chronic pain, chronic disgruntlement. So the action points for clinicians: multidisciplinary collaboration, early intervention, and not forgetting mental health. For the administrators, I'll plead for allocation of resources to increase the number of case managers. To the policymakers, funders, and payers, again, They need to value and reimburse holistic and coordinated care, increase the funding of MVA funds, equipping of more government facilities, because that's where the bulk of patients go to. And that's where they slip through the cracks. And then MVA has to assist with their care at 2, 3, 4 times the cost. We also need to maintain the private-public partnership value chain. Thank you.
Thank you, Dr. Ngobe. Sometimes it's two things: your hieroglyphic handwriting as doctors, and then the terminologies. I didn't see much of those today. Thank you, Dr. for that. We could follow. And some of us are even thinking to divert and take after you, looking at the names and all these things. As for us, Dokotela, if I were to speak Siswati, you know, when we've got the pot and then it starts to whistle, it means the food is ready to be taken out of the fire. So I'm just ready to be taken off the fire. Otherwise, I would have emulated you, Dokotela. Thank you very much for these insightful presentations. These are the difficulties, Dokotela, MVAs deal with. High expectations, some of which are not related to the injuries, or rather when those injuries have not been incurred through the MVAs, they've been there. And then the moment the people come, they'll just give you a plethora of all these things that are as a result of the injury. And some of them would even probably approach the fraternity of His Lordship to say, I am being cheated. But in all this, they are injured and aggrieved parties. It remains our principal and fundamental duty to ensure that we steady them across the processes and they understand what is due to them medically and in compensation, and also what is not part of this process. It takes time. Announcements. Remember, she's the lady who made me mess the program successfully. Okay. This one is good news, really. Good news. It's Christmas in October. That as we are going down to lunch, we have gifts outside. Gifts galo. And Tengedile shall guide. I can see a fellow there with arms akimbo. Smelane. Are you Dr. Smelane, by the way? I'm looking at the classes. You know, when we grew up, only doctors were allowed to wear glasses, not everyone. As we go down to lunch, let us indulge in the things Dr. Ngobe was presenting here, so that maybe they also form part of our discussion later this afternoon. Ladies and gentlemen, lunch is served and is downstairs. Thank you very much. It shall be an hour. Hour. What time is it?